Hey there, future surgical superstars. We have a really important mission today, helping our patients on blood thinners get through their surgeries safely. Every single case is its own special puzzle, and you know what? I'm going to need your help to solve them. Let's get started.
Every decision we make is kind of like walking a tightrope. On one side, there's the risk of too much bleeding during the operation. And on the other side, well, that's the risk of a dangerous clot forming, which could cause a heart attack or even a stroke. Our job is to walk that tightrope perfectly for every single patient.
Okay, team, this is it. We've got 5 patients today, and each one has a unique puzzle about their blood thinner. So, are you ready to solve these cases with me? Let's do this! So our first case is all about heart stents. These are those tiny little tubes that keep the heart's arteries open, so the stakes here are super, super high. This puzzle is called the stent clock.
All right, check this out. Our first patient is a 68-year-old man who got a drug-eluting stent 4 months ago, and now he needs surgery for cancer. So, what's our plan for his dual antiplatelet therapy? That's his DAPT. Do we A, postpone the surgery, B, continue both meds right through, C, stop his clopidogrel but keep the aspirin going, or D, stop both of them? Okay, kid doctors, pause now and think for 5 seconds. And the answer is C. You got it. Stop the clopidogrel, but definitely continue the aspirin. You are doing amazing. Now, let's figure out why that's the right call.
Okay, so let's look at this timeline. For a normal, planned surgery, we'd really want to wait a full 6 months after someone gets a drug-eluting stent. But his cancer surgery is time-sensitive. We can't wait. The good news is, the guidelines say that for urgent cases like this, 3 months is an okay window. So, at 4 months, he's clear. But here's the most important part. We have to keep the aspirin going to protect that stent, but we can safely pause the clopidogrel for a bit to lower the bleeding risk.
Great work on that first one. You're really getting the hang of this. Let's move on to our next puzzle. This one is a classic, a question that even big-time surgeons have to think about really carefully. It's called to bridge or not to bridge.
All right, next up, a 75-year-old woman with a mechanical mitral valve. She's on warfarin, and she's scheduled for a knee replacement. Now, warfarin takes about 5 days to wear off. So what do we do in that 5-day gap? A, just stop it and that's it. B, stop it, but use shots of a shorter-acting heparin as a bridge. C, just keep the warfarin going. Or D, switch her to a heparin drip. You've got 5 seconds.
And if you chose B, you nailed it. We need to stop the warfarin 5 days before, but we absolutely have to use a heparin bridge. Let's see why this is so important.
This is the key right here. See, we don't bridge everybody on warfarin anymore. For most patients, it just causes more bleeding without much benefit. We only bridge the patients who are at a really high risk for clots. And we can remember them with this awesome mnemonic, STREAM. And look, there, at the M, that stands for mechanical mitral valve. That kind of valve has a super high risk of clotting, so we 100% need that heparin safety net while her warfarin is taking a little break.
You are on a roll. Okay, let's talk about the newer blood thinners, the DOACs. I like to think of them as the speedy racers of the blood thinner world. They turn on fast and they turn off fast, which means they have their own special set of rules. Okay, here's our next case. We've got a 65-year-old on a DOAC called dabigatran, and he needs a high-risk spinal surgery. Now, the big clue here is his kidney function. His creatinine clearance, or CrCl, is 40. So how long before surgery does he need to stop his medicine? Is it A, 24 hours, B, 48 hours, C, 72 hours, or D, 96 hours? Let's take 5 seconds. Go. And the correct answer is D, a whopping 96 hours. That's 4 whole days. I know, that seems like a really long time for a speedy DOAC, doesn't it? Let's look at the chart that explains everything. So here's the deal. Dabigatran gets cleaned out of the body mostly by the kidneys. If the kidneys are working a little bit slower, like our patients are, that drug just sticks around for much longer. And since spinal surgery is a place where bleeding is a really big deal, we have to be extra safe and stop it a full 4 days ahead of time. See? It's all about connecting the drug, the patient, and the type of surgery.
Uh-oh, an emergency. We have a 55-year-old on the DOAC apixaban, and he needs surgery right now after a car crash. He took his last pill just 3 hours ago. We've got to reverse it, and we have to do it fast. What's the best reversal agent? Is it A, idarucizumab, B, 4-factor PCC, C, low-dose andexanet alpha, or D, high-dose andexanet alpha. This is urgent. You've got 5 seconds.
Yes, the correct answer is D, high-dose annexanet alpha. Great job! Let's pull out our emergency reversal kit to see why. Think of it like this. You have different keys for different locks, right? Well, it's the same idea here. We have specific antidotes for different blood thinners. Idarusazumab is the special key for dabigatran, and PCC is for warfarin. For the ZAX inhibitors, like our patient's apixaban, our special key is andexanet alpha. And because he took a full dose just a few hours ago, we need the high-dose version to make sure we reverse all the medicine in his body so we can operate safely. You are doing an absolutely incredible job, team. We're already on to our final case, and this is one you will see all the time, and it's a question where the answer has actually changed a lot in recent years. It's the aspirin question. Okay, our last patient is a 70-year-old man who takes a baby aspirin every day for what we call primary prevention. That just means he's trying to prevent a first heart problem. He doesn't have any stents or known heart disease. For his routine hernia repair, what do we do with his aspirin? Do we A, continue it, B, stop it 7 days before, C, increase the dose, or D, switch to a different drug? Let's solve our final puzzle. And the correct answer is B. We stop the aspirin 7 days before his surgery. Now, this might be a surprise to some people, so let's look at the really strong evidence that tells us why this is the right move. This all comes from a huge, game-changing study called the POISE-2 trial. It basically taught us that for patients just like ours, who are taking aspirin to prevent a first problem without any stents, continuing that aspirin around surgery time doesn't actually stop heart attacks, but it does cause more serious bleeding. So for him, that tightrope is unbalanced. The risk of bleeding is bigger than the benefit, so we stop the aspirin.
You did it! You solved all 5 puzzles, and you helped every single one of our patients today. You are all officially surgical superstars. And to help you remember everything we learned, I made you a special high-yield cheat sheet.
Here they are, our top 5 pearls. First, remember the stent clock, B30D612. 30 days for bare metal stents, 6 months for drug-eluting. Second, the POISE-2 rule, no aspirin for surgery in patients without stents. Third, with warfarin, you only bridge the truly high-risk stream patients. Fourth, for DOACs, the whole time depends on the surgery and the kidneys, and you never bridge them. And finally, know your reversal agents cold. Go on and take a screenshot of this. It'll be super, super helpful. You all did such an amazing job today. Thank you for all your help in the operating room. If you want more friendly exam stories with little surgeons like me, don't forget to like and subscribe to ABSITE Daily Dose. I'll see you next time.